so much for being here and for sharing your Saturday morning with me. Before I start, is there anybody here who speaks Kinyarwanda? Good, because I'm about to mispronounce this. Okay. Abishize Hamwe Antikibananira is Kinyarwanda for nothing is impossible for those who work together. And what I'd like to talk about today is a project that I have been working on together with many of my colleagues at the University of Rwanda, in the School of Social Work, in the School of Nursing, in Public Health, and also in the Ministry of Health. And also Canadian colleagues at York University, but also at Western, the University of Manitoba, and St. Thomas University. And I want to touch on a number of projects that we have done that have looked at the concepts of social support, social welfare, and resilience in the Rwandan context. And I'd like to today try to talk about why doing this kind of work in the Rwandan context is an example of global health research and what we mean when we do global health research. So, Rwanda is a very small country in East Africa. It only has about 11 million people. It is quite a poor country. It's in the middle of the bottom third in terms of overall wealth around the world. The average income per capita is $1,150 US per year. The average lifespan, 56 years. And when you look at education, secondary education is finished by approximately 8% of the population. Now that number is increasing because one of the things that's been really interesting about Rwanda is how rapidly they are building healthcare systems, educational systems. And most people don't know very much about Rwanda because it is quite a small country, but when I tell people that I work in Rwanda, they tend to think of one of two things. Rwanda has one of the only two populations of mountain gorillas in the world. This is an endangered species, and one of these clusters is in the Virunga extinct volcano, which is on the border of Uganda and Rwanda. And every time I fly to Rwanda, there's a tour group on the plane with me going to see gorillas in Rwanda. I've been 11 or 12 times. I have never seen the gorillas in Rwanda, but I hear that it's a beautiful park and that it's a beautiful place to visit and worth going to because Rwanda has invested in low volume, ecologically responsible tourism. So it is actually, although incredibly expensive, you are investing in both the community and in the animals. But that's not what most people think about when we talk about Rwanda. Most people remember Rwanda in 1994. After years of conflict between Hutu and Tutsi, there was an explosion of violence that lasted 3 months, where somewhere between 500 and 800,000 Tutsi and moderate Hutu were murdered by neighbors, community members, people from the village next door, killed with farming implements and machetes, burned in homes, in churches where they had taken refuge. Approximately 250,000 women were raped. Many of them were intentionally infected with HIV. Every colleague I work with has lost family members in the genocide, often more than one, sometimes all of them. After the genocide, when the country began to rebuild, we saw an amazing transformation as the people in Rwanda came back to the villages they had left, living side by side with people, not who had committed the murders, because those people were in jail, but with community members who looked the other way, who didn't provide shelter, who perhaps moved into their land and started farming their land after they were gone. And somehow Rwanda has managed to bring people back together side by side in these communities and to redevelop and move forward. And what's really interesting about the Rwandan experience is that they have very consciously gone back to their traditional values, to use those values to rebuild a sense of shared collective identity and strength and resilience. Rwanda is an agrarian culture. 90% of the population continues to work in very small plots of land for farming. And most agrarian cultures have a strongly collectivist notion of the self and your relationship to the community. Your relationship to the community and your social roles are more important than your own individual aspirations. This plays out differently in different cultural contexts. In the Rwandan context, it results in the kind of saying that you saw earlier, and in other sayings like, Ijidi kimwe and tikigora ishyamba. A single tree cannot form a forest. And I'm not even going to try the next one. Where there is no conflict, a single rabbit skin can be a bed for 5 people. An emphasis on how we cannot survive alone. And if we work together, we can survive. At the same time, Rwandans really value self-sufficiency. And the idea that while it's important to support one another, we also have it within ourselves to be self-sufficient. And we should all be aspiring to be self-sufficient. And so, for example, Akimuhana kaza imbura ihise. Don't wait for help from others. You have the means to help yourself. So we have a community that's highly mutually supportive and interdependent, but also very entrepreneurial. And the government has very consciously reenacted traditional practices that had fallen out of practice prior to the genocide to once again re-embody and reinvigorate these values. And they're using them in their social welfare policies. To give you a couple of examples of how they're doing that, they continue to have, at the end of every month, an umuganda, where you go back to the village where you're registered, and every member of the community works on a collective project for the community. Umugoroba Wabayei is where the community comes together and elders will help families resolve family conflict. Girinka is a policy where the community identifies families at need, and those families are given a cow. Again, this is a very agrarian culture, so getting a cow makes sense. It wouldn't make sense in Kigali, but it makes sense outside of Kigali. And the family can not only use the milk and sell the milk, but when that cow has a calf, they then give that calf to another member of the community who needs that support. So building not only self-sufficiency, but that mutual network of support. So there has been a lot of international interest in mental health in Rwanda, and that interest has taken a couple of different paths. One of them is what I would call the international health path, where high-income countries go to lower-income countries and try to impose some kind of high-income solution on that country and then leave again. And we see that a lot because of the genocide. So there have been a lot of international agencies coming in and saying, we're going to help you with PTSD. And we're going to work with you to deal with the trauma that you've been through. Partly because of guilt for not intervening to prevent the trauma in the first place, or guilt around the fact that those conflicts emerged out of a history of colonialism. But there was another reason to come to Rwanda to talk about mental health, and that is, here's an example of a community that has been through an incredible trauma, that is rebuilding and demonstrating a remarkable model of resilience. And we can learn about resilience by seeing how Rwandans are addressing resilience, and see whether that's something that we can apply in other settings, including here. So let me just briefly talk about the global mental health movement and how this project fits into that framing of global health and global mental health. As Leslie was saying earlier this morning, global health says that health issues cross boundaries. They don't stay within one country. Mental health is an example of a health issue that is shared across borders. Issues like depression, epilepsy, schizophrenia are experienced around the world. And one of the ways that we can address these problems is by actually forming transnational, global communities of care or concern around these issues. And so we can think about how to address issues of resilience and social support in an international, transnational way. And the reason it's important to think about these issues transnationally is because we are all increasingly interconnected. We are interconnected because our health and well-being is affected by our social environment, our physical environment, and the political environment and economic environment that we live in. And we cannot pretend that those factors are not all international and interconnected. Our environments are affected by what happens in other countries. Our economies are affected by international relationships. And those global interconnections mean that anything that happens in one country is actually going to affect all of us. So if we want to address these transnational health issues, we need to think about them in a transnational way. But there's also opportunity in this. It's not just a need. We have an opportunity to understand universal aspects of health issues by seeing how they differ across different kinds of social, political, and environmental contexts. We have an opportunity to look at interventions happening in other countries and learn from them and think about how we could apply those in our own setting or in other settings. And frankly, we have a lot of technology. We hear about each other's practices and beliefs. We engage in them. We're affected by them. So we are all influencing each other anyways. Let's be explicit about it. The problem in the mental health sector, however, is that mental health, even more so than other kinds of health issues, is very deeply embedded in our social environment and our interpersonal environment. How you understand depression will be determined by the culture that you've grown up in. In Rwanda, there is no word for depression. And when they talk about PTSD, they use the English word for PTSD. It's just not part of the discourse. So how do you understand these mental health issues if you don't even have a word for it? So there must be a different way of conceptualizing it. And that means that if you want to generate interventions that work in different settings, you have to find some way of connecting to local conditions and local understandings, and at the same time connecting those local conditions and local understandings to some global or universal understanding. And that's really hard to do. But that really is the core of the work that we are doing here. So the first project I want to talk about is really addressing this tension between local and global in the context of the work being done by social workers in Rwanda. This is a project led by Susan McGrath, who's here at York University. I'm a partner on this project, and she's been working with the School of Social Work in Rwanda now for over 10 years. And York University has been instrumental in developing this Center for Social Work Education and Practice at the University of Rwanda in Butare. Social work is a relatively new practice in Rwanda. Prior to 1998, it really existed as almost like a home economics course. It was about hygiene and about practices in health in domestic settings. And it was really only in the 1990s they began delivering a Bachelor of Social Work. And that Bachelor of Social Work is being taught by people who are Rwandan, but who have gotten their PhDs in social work programs, mostly in Europe. So you have European models of social work being taught to Rwandan social workers to practice in Rwandan communities, many of them in very rural communities. And the question is, how do you bring together this international knowledge about social work and bring it to communities that already have a history of social welfare practices? How do you incorporate your own understandings of social well-being? How does that fit together? Because if we can figure out how to do it in Rwanda, maybe we can also figure out how to do it in Canada, where we also have highly international communities. When we spoke to social workers about how do you engage in helping others, what does it mean to provide support in your community, they talked about a notion or concept called urunana, and they drew a picture of people standing in a circle with their arms around each other. And they said, it's about this collective interdependence. It's about people having togetherness, solidarity, unity as a group. It was very much a group phenomenon. This is work done by somebody else. This is by Betancourt, who's at Harvard. She's also worked extensively in Rwanda, and she came up with very similar notions of the importance of the collective when she looked at how youth protect themselves in the context of mental health. And she found that when youth talked about what protected their mental health, they talked about things that were, in most cases, about their relationships with others. So 5 concepts seemed to emerge. One that really focused on patience and perseverance, but a big part of that was perseverance in remaining connected to other people. Being optimistic about the future and thinking, using future-focused thinking. A strong collective identity with your family. Good parenting, strong relationships with your parents who are teaching you the skills that you need and are showing you love and support. And then finally, explicitly communal and social support, which is being part of an inclusive community. Again, this notion of your embeddedness in a larger social context. So there is this notion emerging of a kind of collective resilience. That's social support, strength, and well-being are not part of a one-on-one relationship, but part of being a member of a connected community. When we spoke to social workers about how they provided support for members of their community, they did talk about things that we would recognize as traditional counseling practices in the medical profession, if you like. So for individuals who are experiencing extreme distress or grief, they would offer active listening, empathy. A good example here from one of our practitioners. They benefit from counseling and workshops. The truth is they need active listening so that the sorrow that lives on in their hearts can be expressed with someone with a listening ear. Someone who can put her or himself in her skin or shoes and show her hope in life. But this was really only used in the most extreme cases, and most of the strategies that they used were about promoting people to join collective groups and receive mutual support, engage in a mutual supportive relationship. And they would talk about how important that was to not only helping individuals, but to building community. There's a quote from another one of our participants: "We facilitate understanding of those who help implement that understanding at the grassroots level." So they supported people who supported others in the community. Those people were typically volunteers. There's a strong network of volunteer community health workers in Rwanda. When a neighbor becomes your teacher, and you are a neighbor to him, there's better understanding than when activities are performed by people from above, because they say, those are things of the educated people. But when they come from a neighbor, they have power. The idea that knowledge, that power, that connectedness is critical. A couple of other things that emerged in our conversations with how Rwandans practice social support and how our social workers were practicing social support also talked about how you actually identify support needs in your community. And one of the things that came out as being really important was that you don't wait for people to come to you to ask for help. You actually identify who in your community might need support, and you go out to them and offer them help. The other issue that came up was that you don't have to have these long, in-depth conversations. Sometimes it's just your physical presence. That is enough. So you go to people that you know are in distress, and you just sit with them, and you just be with them. And that is also part of providing social support. So what was interesting in what the social workers were telling us about how you practice social support and social helping in the Rwandan context is that it's very strongly grounded in these Rwandan values of mutual support and self-sufficiency. But it also strongly reflects this idea of a collective resilience. And so we took that idea going forward and said, how can we apply this in a global mental health framework? So working with our colleagues, we talked about, can we develop some kind of sustainable mental health intervention in Rwanda? The reason sustainable is really important is because of something that's called the mental health gap. Most individuals who require mental health services or could benefit from mental health services don't get them. In high-income countries, depending on the kind of issue we're talking about and the country they're living in, 30 to 50% don't get health care that they could benefit from. In low-income countries, that number is somewhere between 76 or 80%. Where there is care in low-income countries, there are typically limited resources, and health resources tend to get spent on those kinds of health issues that are associated with infectious diseases or mortality. When you get mental health care at all, it is typically only custodial care in a hospital. So you get put in a hospital and left there. There's very little in the way of community mental health services, and there are very few specialists at the community level or all the way up. In Rwanda, there are 6 psychiatrists for a population of 11 million people. One of them isn't practicing. So, given the limited resources, given the issue of sustainability, given the fact that most people are not going to be able to access mental health care, if you really want to do something about mental health care in a low-resource setting, you really want to think about an intervention that is sustainable, where you don't come in, put something up, and then when you leave, you take the resources with you. You need to leave that intervention behind. It has to be able to run itself. And we also know from mental health research that prevention is far more effective than treatment later. So an intervention that prevents mental health problems is really the best way to go forward. And finally, it has to be locally relevant. So given the Rwandan context, we want to build on these existing values of collective support, of mutual support, and resilience. So we talked about using social support. I've been talking about social support. Let me give you a formal definition. It's the perception or receipt of emotional, informational, or material resources that you need when you need them. And it has been associated with improved physical health, reduced mortality, and improved mental health around the world. So the issue that we try to apply this to is another global mental health issue, which is perinatal depression, which I'm going to be talking about the day before Mother's Day, which seems insensitive. Thank your mothers, because the period during pregnancy and in the year following birth is associated with the highest risk for mental health problems for women. And the most common mental health challenge that women face during this period is depression. And yet, despite that, around the world, maternal depression is generally undiagnosed and untreated. And this is true in Rwanda also. And it has really serious consequences, not just for the mother's physical and mental health, it also has consequences for her infant. That first year of life is where your brain is growing and developing. So anything that interferes with that year of development can have long-term serious consequences. And we see that maternal depression is actually associated with both cognitive and emotional development issues and delays for children. In low and middle income countries, which is what LMICS stands for, low middle income, maternal depression is also very strongly related to childhood malnutrition. And childhood malnutrition is one of the leading causes of infant mortality. That relationship is so strong that some people have argued that if you could eradicate maternal depression, you could reduce infant mortality by 30% in low-income countries. This is a huge impact. So it's an important issue. What are the risk factors? Around the world, those risk factors are poverty, low education levels, previous exposure to trauma, prior mental health problems which make you more vulnerable in situations of distress, and a lack of social support. So you can see where I'm going with this. So we thought, could we do something around building social support in the Rwandan context as a way of using Rwandan values and notions of collective resilience, by connecting new mothers to the resources that they need, including referrals to additional care if they actually need referrals? Can we reduce the prevalence and impact of perinatal depression by strengthening these support networks? And can we do this in a way that is sustainable, so it can keep going after we're gone, so it becomes part of the fabric of how we do work in Rwanda? So we created an intervention that lasted 1 year. It started with looking at depression and social support among new mothers in 60 communities in a province of Rwanda called Bugesera, which is just southwest of Kigali, and a very poor province. Not the poorest, but a very poor province. 6 months later, we go back to see, is there a relationship between what was happening 6 months ago and where you're at now? And we bring into place an intervention. We train local community women leaders around issues of maternal mental health so that they can identify women who might need additional support. And we talk to them about active listening, framed in a way that's consistent with Rwandan practices. Those women now visit all the new mothers in their community for a period of 6 months, about once a month. And at the end of the 6 months, we come back and we measure the mother's depression, how much support they think they're receiving, and also the impact on the children's weight and height. Did we have an effect? Well, first, let me talk about the risk factors. The risk factors for depression were very prevalent in Rwanda. We were working in a relatively poor province, but we were randomly selecting women from across the province. We used they've now changed their socioeconomic scale measure, but at the time that we started the study, the scale that they were using had 6 categories, and the bottom 4 were all measures of poverty. Every one of the women in our study fell in those bottom 4 categories. Half of them had not enough money for food, had no permanent housing, no clothing, and were starving. I mean, we're talking extreme poverty. 18% of them had experienced gender-based violence. 20% had experienced some form of childhood sexual abuse, so a history of trauma. This is a country that's experienced a genocide, so just like with my research colleagues, Many of them have lost family members. 58% at least one parent, 69% at least one sibling. So they're vulnerable. And when you look at their rates of both prenatal and postnatal depression, we see that those rates, they're the green bar, are about 20% for the women in our study. In other low-income countries, the average is around 16%. In high-income countries, the highest average is around 12%. The worse the social conditions that you find yourself in, the greater the risk of mental health challenges. Postnatally, it was 24%, again higher than other low-income countries and higher than high-income countries, reflecting the very difficult social conditions these women are living in. So what predicted depression? Without any intervention, what's the relationship between how you were doing at time 1 and how you're doing at time 2? Well, it turns out that, not surprising, if you were depressed at time 1, 6 months later, you were more likely to be depressed at time 2. There's a certain amount of consistency across this. But husband's support was a strong predictor of women's depression 6 months later. For women who had infants, for women who were pregnant, it was the support of their friends and their peers. Now remember, we only asked about emotional support, but support also includes bringing of resources and other kinds of benefits that you might get. Especially in a resource-poor community, this is very important. We looked at the children's outcomes, and in particular we looked at stunting, which is the child length for age. And stunting reflects long-term malnourishment because the body stores resources if there are very few resources in the community, and so extended periods of malnutrition result in smaller babies. They may be of normal weight, but they're smaller, shorter. Let me see if this works. Nope. The yellow wedge, that's the percentage of infants who were at the mean length for age on universal international standards or higher. The blue were those who were below the mean, but still within the mean and -2 standard deviations below the mean. 46%, the green wedge, were stunted. More than 2 standard deviations below the average standards of length for age for infants. So a portrait of a community that is really struggling. And what predicts stunting? Now looking a year later, we've had a year now to look at long-term impact. For women who had infants at time 1, anxiety and social support, not depression. And for women who were pregnant at time 1, social support. Across the board, social support was a strong predictor of mental health outcomes and physical health outcomes. And it wasn't that depression was predicting the mental health outcomes and the child outcomes, it was that social support was doing this work. Did our intervention work? So we didn't get, while social support was really important, we had funny things happening with the social support that women were receiving. And it was complicated by the fact that our community women leaders spent the most time with the women who were in the greatest distress. And that meant that the people who were getting the support were also the ones who were doing the worst to begin with. And so it was hard to demonstrate that they were actually getting better. And interestingly, the neighbors of women who were getting social support interventions began to withdraw some of their support. So it created some kind of hostility in the community. So we may not have gone about this the right way and really need to be more collective in how we're supporting these communities rather than isolating individuals, bringing individuals together. But those women in the intervention were being connected to all kinds of additional services. They were getting connected to health insurance, mental health references, and other kinds of housing and family support. And the local authorities were saying those community women leaders were now acting as a bridge for us, so we knew more about the needs of the women in the community. And they really pushed for continuing this program now that we're gone. So they're going to try to continue to support this program on their own. So what have we learned working in Rwanda? What we've learned is that social support is critical and may be one of the most critical pieces in low-income as well as high-income countries. That being connected to your community is a strong predictor not only of physical well-being, but also mental health and well-being. And we've also learned that we need to think about how support is offered. So here's one of those you need to be culturally sensitive moments, that there is a lot of research in other cultures that suggests the same thing. Having to ask for support in other studies has been found to actually lead to poorer mental health outcomes. Because in a culture where people are supposed to be paying attention to each other, where people should know what your needs are, to have to ask for help both reflects that you're not well connected to your community and means that you're a burden on other people in your community. So people, in fact, do worse in some communities when they have to ask for help, and Rwanda may be one of those places. But we've also uncovered another piece of what might be a universal aspect of social support, and that is there is some work that suggests that the way social support works at the emotional level is that you regulate how you're feeling just by being next to somebody else. That mere physical presence actually matters. And so that's one of the other universal lessons that we may be getting out of the work that we're doing. So how are we working going forward? We're going to continue to try to build social networks for new mothers using strategies that are more inclusive, not just targeting new mothers, but now maybe targeting all the women in particular regions. And we're trying to argue that you don't have to do anything really complicated like therapy, you just need to show up. Just being there may actually be enough. Just some active listening may be enough. We need to look also at how social workers are incorporating international knowledge and local knowledge and reproduce what they've been doing in Rwanda to bridge those two kinds of knowledge into how we teach social work and other kinds of service practices here and elsewhere. And finally, we need to broaden how we think about social support and resilience. So it's not always one-on-one, that we recognize that social support and resilience are also part of, or also include being part of a strong, connected community. I don't think that that's absent in the North American context. I just don't think we talk about it in the North American context. So we need to be more cognizant of how our membership in meaningful and important groups, whether those are religious groups or family groups or community groups, is equally important to our health and well-being. So I just want to say thank you for the many, many people who are involved in this work. This is the social work group in Butare at the best restaurant in Butare, as far as I'm concerned, which is the Chinese restaurant in Butare. And thank you to all of you for listening.